Greetings, everyone. Welcome. Thank you for joining Quest today. We know that all of you have a lot going on, and we just really appreciate you spending the time with us. It's so important during these times that we come together with our mutual interests in research and learning, and we really think you're going to enjoy today's session. So on behalf of Quest, I would like to welcome Emily Kervin. She's going to introduce herself in just a moment. Just wanted to do a little bit of housekeeping for today. So everyone is automatically muted just for now. And what Emily will do is she's going to talk a half hour or so. And then you can feel free, as she's speaking, you can put questions in the chat box. And then she'll be happy to address your questions when she's finished. And that's it from this end. So without further ado, I will welcome Emily so she can teach us all kinds of interesting things about her studies.
Thanks, Monique. Just going to get my screen shared here. Alrighty. So I'm assuming that looks good for everybody. It looks good for me. How does that look? Okay, thanks, Monique. So thank you, everybody, for tuning in today, especially during all the craziness of the pandemic. So I certainly appreciate it. My name is Emily Kervin, and I'm the research coordinator for the SOAR team at Horizon Health. And today I'm going to be talking about our transitions project. And so the title of the presentation is Using Mixed Methods to Investigate Hospital-to-Home Transitions for Frail Older Adults in New Brunswick. And so I'm just going to give you a little bit of a background for the project. It is a CFN-funded project. And so our project lead is Dr. Rose McCluskey and co-principal investigator Dr. Pamela Jarrett. I'm sure familiar names to a lot of us. And as well, I've listed all of the co-investigators here. And so you can see we've got people representing all sorts of various areas of expertise, which is fantastic. I wonder, I'm just gonna get rid of this here, sorry. Okay. And so the purpose of the Transitions Project, the overarching purpose was to develop practical recommendations for policymakers and clinicians on how to promote successful hospital-to-home transitions for frail older adults. And so for the piece that I'm going to be talking about today, the purpose was to determine points of vulnerability as well as opportunities for improvement within these really complicated transitional processes. And so here's my little graphic that I'm super proud of. Just kind of illustrating that these are kind of, we're just looking at the areas of vulnerability within this process. Okay, and so we're talking about the transitional processes for frail older adults who are discharged from geriatric hospital units to their homes in the community, just to clarify. And the transitional process was defined as the time period from a referral to the hospital unit that provides the geriatric care to 3 months post discharge. And as well, to provide a comprehensive overview of what that transitions process looked like, we had 3 different study sites in 3 different cities in New Brunswick. So I just have a little overview slide here for the methodology. And I'll go into a little bit more detail for each of these phases, but you'll see I'll focus today on phases 1 and 2, but right now we're kind of in phase 3, working on our policy analysis and trying to get some KT done. So that's where we're at now. In terms of phase 1, this involved interviews with 5 frail patients and 7 family caregivers of these frail patients. We also conducted semi-structured interviews and focus groups with healthcare professionals. And so we had focus groups at each of the different hospitals that had the geriatric units in them. And so we had a total of 27 participants there, which was great. And then we actually conducted analysis of phase 1 data before we collected the phase 2 data, and we utilized thematic analysis, iterative thematic analysis rather, and in vivo 12 Pro, which was fantastic. And so for phase 2, this is really where a lot of the fun began. So we used prospective multiple case study methodology. So we had 3 study sites, like I mentioned, which were in 3 cities in New Brunswick, and 6 cases. And so each of these cases consisted of a patient and their family caregiver. And in terms of our analysis, we utilized case description within case thematic analysis, as well as cross-case synthesis of themes. And so when we looked at phase 1 results with the phase 2 results, this provided triangulation for us. And also throughout this process, we noted site differences, which was really interesting. And I do have a couple of notes in there to share as we go through the results, which I think are really cool. And we also noted any of the stakeholder differences in perspective. So differences between the patients, caregivers, and healthcare providers. Okay, so I'm just going to give a little overview of each of our kind of case study measures so you can have an idea of what information we were working with as we conducted our analysis. So for phase 2 as well, we had some interviews with patients and caregivers, and these were conducted by a research nurse who was a research assistant for the project. And so she actually went to the homes, this was pre-COVID, of course, of the case study participants and collected the data right there with them. And so these interviews were semi-structured and they were about the hospital to home transition. And so there was one conducted prior to discharge, as well as post-discharge at 1 week, 1 month, and 3 months. And as well, the research nurse made note of at-home observations as well at those time points. The post-discharge time points, I should say. And just to show you what demographics we collected: age, gender, marital status, race, ethnicity, education, employment status, and as well, we made note of the relationship between the patient and the caregiver. In terms of standardized measures, for caregivers and patients both, we use the clinical frailty scale, the self-report Charlson comorbidity index, the Connor-Davidson resilience scale, and for the caregivers only, we use the apathy evaluation scale, and then for patients only, we use the mini-mental, the geriatric depression scale, the instrumental activities of daily living, and the physical self-maintenance scale. We also collected data on self-reported healthcare utilization, and so this was measured prospectively and involved emergency department visits, hospital readmissions, visits to family doctor, calls to paramedics, extramural program visits, any specialist visits, or clinic visits. So we also had participant observation data, and so there was observation of the interprofessional healthcare teams during weekly patient rounds. And I guess rounds might be a little misleading. It was more like the team meeting for every week for that geriatric unit. And so we had 2 research assistants who attended each site's rounds every week to take notes. And so every week we kind of added and compiled and got those notes, and that ended up generating quite a lot of data. As well, textual review. So what this was for us was obtaining the information from the patient's medical records concerning their hospital admission, the hospital admission of interest for us. And so information like the date that they were put on the geriatric wait list, the date of the hospital or geriatric unit admission, which sometimes differed, if they were on the wait list for a while. The reason for the hospital and geriatric unit admission, any diagnoses, their baseline clinical frailty and mini mental if those were collected, the discharge dates, and any documentation that was associated with the care transition. And so this might have looked like the consultations that they may have had, or discharge instructions that were given or made note of in the system. And so this part was fairly time consuming to go into each of those records and kind of pull everything that was of interest, because we really had to go through everything that had to do with that visit, and it can be quite a lot. So it was time consuming, but generate a lot of really interesting data as well. So that's the rest of the measures for the case studies. And we also conducted some member checking. And so we produced a written summary of the notes taken during the team meetings. And so the team meetings being the geriatric team meetings, and circulated these summaries to the team members at the end of the data collection period. And so they emailed us back any corrections or any comments or anything that they had to say, and we revised it and then recirculated to all the team members. Okay, so moving on to results. So these are the results of the cross-case thematic analysis together with the thematic analysis from phase 1. And it produced several areas of importance during the hospital to home transition. So we've organized them here as kind of either pre-discharge vulnerabilities or post-discharge vulnerabilities. And so firstly, we have the coordination of discharge. And so a key consideration here was who the point person was, and to what extent the team communicated with the patient and the family and involved them in care decisions. And so we found that there was a lack of communication and confusion around discharge details and logistics. There was quite a lot of variability in the patient and caregiver preparedness for discharge in terms of how prepared they felt themselves for the discharge, and as well as a lack of agreement on the discharge plan between the patient and the healthcare team. And so here are just a few quotes, and I've kind of included them for each part here so we can kind of get an idea of what people are saying. So here's an interesting one. We never sat down as a family and discussed mom's condition and how things were. It was me transferring information to him transferring information to me, and we were getting it a lot of times off of a chart. So there was really kind of this back and forth and, you know, roundabout ways of getting information to people. And so that really came through for us in this project. And here's another one, which is, you know, really sad, unfortunately. There was a lot of confusion about picking her up, because we were told initially that she was going to be released at 3, and then we found at 11 o'clock she'd been released and was waiting around in the corridor. And another one, so you're going home tomorrow. It was like a rumor. This one knew, you knew, and somebody else knew, but I didn't know. Nobody came to me and said, okay, you're going home tomorrow for good. And as well, maybe while I'm on this slide, I'll just comment on some site differences for this discharge coordination. So in one of our sites, we had a social worker that appeared to take on the majority of the role. At another site, each patient was assigned a case coordinator, and that case coordinator was a member of the geriatric team, but there was no dedicated discharge planner on the unit. And then at another site, there was a dedicated discharge planning nurse. Okay, another pre-discharge vulnerability that we found was the transition to home planning. And really this involved, or who is involved and to what extent do the team members plan this transition, and when is the planning initiated following the patient's admission. We found that there was variation in terms of the planning approach, and we suspect this is due to a lack of overarching policy and guidelines. There were wait times for community services and processing times. In cases where a power of attorney needed to be involved, social development, and that could cause delays in the length of stay, the bed availability for incoming patients, and certainly initiation of follow-up services that may have been involved. As well, planning options were limited by what was available in the community and as well families' financial resources. And so here's some quotes here that I have to show this. Yes, you can plan all you want, what you need is not there. So that came through a lot. Basically that, you know, if the service isn't available or there's a huge wait list, then it's basically you cannot plan for that if you can't access it. Okay, the discharge plan, we start talking to family usually a week or two before we're planning for discharge. And I think the family conference is very helpful. We'll invite family members who will come in, hear the recommendations, and I think the chances of the family following the recommendations are greater. Probably one of the biggest barriers for us, though, is that, you know, social development, you know, sometimes the process can be slow. So sometimes it does take a while to get that process, get the services in place for them. And so some of the site differences that we observed for transition to home planning was that for one site, the family conference was consistently held. And they always had the family meeting, and there were several policies for the transition. And another site, the family conference was held when necessary, and there were no policies for transition there. And then for the other site, the family conferences were typically held, although there was no report of a conference for one of our case study participants. So that one was a little bit more unclear. So certainly variability in terms of the planning and the involvement in the family conferences to kind of plan that transition. And so here are some patient caregiver quotes I should have mentioned. These ones were from healthcare providers, but I think you'll see some parallels here with the patient and caregivers. I wish they would have told us if I do have a fall, how to get me up without calling the ambulance. So this person was concerned about having information given to them to prepare them to go home. I suspect the decisions would have happened whatever I had felt about it. So another person kind of feeling a little bit out of the loop and not necessarily considered in the decision-making for the transition planning. You want to know the truth? I wasn't given anything. And so they were referring to discharge instructions there. I just wish I would have had more information about strokes than just given a book. So people really wanted to not just be given just like a pamphlet or, you know, written piece of information, but just something beyond that as well. Okay, and so the third area of vulnerability is home and community care. And so key considerations here is whether the patient was cared for by only family, or do they have formal support in place? Do they have adequate and timely access to services? So access to home and primary care, home care and primary care were very important. Familial support was critical to filling gaps in care. So if they did have some formal care coming in, you know, there's not always access to that round the clock, of course. And so who fills in during those times, right? So familial support was key. Financial concerns. So a lot of the services or the equipment that they needed, like if they needed to rent a wheelchair, rent a walker, those are cost prohibitive sometimes. As well, a lack of resources in the community. So wait times for services and equipment, limited service in rural areas, which was huge. Lack of overnight and weekend care, limited support for caregivers as well. And so the healthcare professionals, some of the things that they said, if everything was set up well, they would get all of those services quickly and easily. I think the transitions home would be a lot smoother. Often the financial cost of homemakers or home supports or equipment is too much. And I remember this quote when, I always remember this one, I find it fascinating. People will go home, they'll take all the free services they can get, or the interim services, or the services they get through the R&R program for as long as they can get. And then it'll get time to pay for services, and they'll say, nope, we can't pay for those services, and they'll cancel all services. So definitely interesting to think about from both the healthcare provider perspective, as well as how frustrating that would be for the patients should they not be able to access those services financially. And patients and caregivers, I have no support that I can go to and talk to and vent. There's no support to show people how they really care for the person that you're supposed to be caring for. And so that was a caregiver saying that, looking for more support and more information about how to care for the patient at home. To wait 5 weeks for outpatient follow-up, to me, is almost like, is he going to regress? So the person was concerned that the patient, by just waiting for those services to become available, whether or not they were going to lose all the progress they had made on the unit. Another caregiver, I have no support other than my son and his wife because I can't afford to bring anybody in. They want seniors in their home, but the resources aren't there. Again, kind of illustrating that if the resources aren't available in the community, then it's really, it doesn't matter what you do. It's you're kind of caught between a rock and a hard place in that way. And so in terms of site differences here, we did see that wait times for post-discharge services are a problem for all sites. And we did notice that one of the sites was receiving more EMP support, while the other two sites, or one of the sites didn't receive EMP support, while the other two appeared to. Okay, so in terms of post-discharge areas of vulnerability, we have the following of recommendations. And so the key considerations for this are how are instructions or recommendations communicated to patients or caregivers? How closely do patients and caregivers adhere to the recommendations, and what factors influence their ability to do so? So take-home team recommendations and instructions are lacking from the patient and caregiver perspective. Patients and caregivers reported wanting more education to feel prepared and to be able to follow through with the recommendations. Not taking up the recommended services. So sometimes this was either a lack of willingness on the patient or caregiver's behalf, or the financial barriers that they spoke of often. Non-compliance with team recommendations. We did read that some people were not reading the discharge instructions or not following their exercise program, or they were using their mobility equipment incorrectly, or they weren't adhering to their medications as prescribed. And some quotes here as well. They know the best way for them to get home is to accept what we recommend. And when we get them back in a fairly short time, because they don't accept the support. So this person was talking about folks who might be discharged, and they do everything they can to get discharged, but when they get back to the community, they don't accept the support that's given to them, and they see them back rather quickly. Okay, another patient perspective here. When I got out of the hospital, I got a bunch of exercises that I have to do. I should be doing them twice a day, but I'm only doing them once a day at the present time. And a caregiver here. I don't always get them to them on time. Does that matter? So that was an interesting thing for us to read as well. They weren't even sure if the medications and the timing of that mattered. And so some concerns there definitely about how prepared they were to care for the person at home, for sure. Another patient perspective. I had the bad habit of walking, holding on to the edge of the counter, which is a no-no, but I managed to get around. So there's somebody who is kind of saying that they're not necessarily using their equipment in the way that they were supposed to. Okay. And so medical follow-up. Are patients receiving follow-up care post-discharge? How and when are appointments arranged? How are questions and new concerns addressed once the patient is home? Are they receiving services that they were referred to? So we observed a lack of follow-up and check-ins post-discharge, that there were gaps in education. And for example, one of these gaps was managing falls at home, and gaps in supports available for patients and caregivers as well. Setting up post-discharge medical appointments was key, but not always the case. New issues and questions arising. So questions about medications, changing health status, those are the things that, people wanted to have access to. Here are some quotes. We have a patient quote. I just sat there with the phone to the family doctor and had it on redial. There was nobody there. This is a quote from a focus group. So when you're talking about continuity of care, the care kind of stops at the door. The patients go home. We're not really concerned about what happens to the patient after. It's a family physician, so because the family physician would presumably take on the care from their perspective once the person's back in community. And so this is kind of illustrating how much of a disconnect there can be between hospital and community. I think that your visits have been very welcome. And this is the person who's referring to the research nurse, actually, who was visiting them to complete measures and interview them. Because you've been informative, you've been giving me some good tips and pointers. I feel like I've got somebody to talk to. Okay, and so this is just another kind of summary slide that has all of these points of vulnerability summarized again. And so we've arrived at these points of vulnerability, which are opportunities for improvement, certainly. And one of the things we also really want to find out is what would a successful transition look like? And how do you define success? So briefly, where the clinician cited factors such as safety, not being readmitted, and having realistic goals and expectations, the patients and caregivers felt that success was a return to family life. And a point of agreement for a successful transition was that family support was critical to success. It's all in the help you have, as one patient said. And that a team approach to patient optimization is used, as well as the patient achieving some degree of rehabilitation. And so these major areas of vulnerability or opportunity and knowing what's involved in a successful transition from various perspectives are really great kind of foundations for us for policy recommendations as we work through that piece at the moment. So I'm just going to end with some reflections on using mixed methods with the transitions project. I know we're kind of coming up on time here, so I'll try and be brief. So one of the challenges, but something I think that we managed well, was the sheer quantity of data that we collected. So as you might have seen, we had quite a list of things that we were collecting, and we had, just massive amounts of data. And so I think there's a challenge there, and like, how are you going to organize that so that it becomes manageable? And so, yeah, it was a lot to wade through, but that, shows the importance of having a team to conduct the analysis. So we had a team-based analysis, which was a strength. And certainly when you're wading through that much data, an iterative approach definitely helps. And that was definitely key to managing the quantity of data and to be able to discuss what we were finding on the regular to avoid getting lost in all of this data, and then creating kind of manageable chunks as we go along. Yeah, and so also planning your approach to organizing the data is something I had reflected on a bit after realizing just how much we had collected. And so I mentioned that we were using in vivo 12. And normally, you do think of that as, something that supports your ability to conduct analysis, but also I think it's important to think of it as a holding space too, and a really important organizational tool. So for us, we created different folders and had one for each of the cases in our case study. And so we were able to kind of get a better handle on the organization as we conducted the analysis. So as I reflect, I think that was a really valuable thing for us to have done. As well, the importance of member checking. So I think this project demonstrated one of the reasons why this is so valuable. So we had circulated summary versions of the notes taken during the weekly team meetings to people who had participated in those team meetings. And so at some of these meetings, not all members spoke in great detail, or for some professionals, we didn't have that deep of an understanding of what their role was in patient care. So when we received a few responses back in response to them receiving the summary of the notes, some of them detailed more what their role was and kind of clarified a few things for us and gave us some information we wouldn't have obtained otherwise. So it was especially important to kind of understand what the team members' roles were, given that the emphasis that the healthcare providers and patients and caregivers placed on having a team approach to care. So certainly member checking was valuable in this project. As well, having an insider on the team was another huge strength for this project. So you may have noticed that I said that there was a quote from one of our case study participants, and they were talking about the research nurse and how valuable it was to have them come visit them because they felt like they had somebody to talk to. Well, this research nurse had also worked, on a geriatric unit as a nurse for a long time, and she had all these connections, and she was already comfortable in this kind of environment. And so having somebody like that to be able to go and collect the data from participants and conduct the standardized measures, like, that was invaluable. And I can't think of what we would have done without her. So certainly having an insider, somebody who has that experience and that knowledge and those connections is, yeah, fantastic for sure. And yeah, lastly, involving individuals from various professional backgrounds. So for this project, part of this project, I guess, which I'm not really presenting today, so I could kind of narrow into the pieces that we were more involved in. But there was another piece where we're more involved with folks at Memorial Engineering, and we were using this software called FRAM, Functional Resonance Analysis, I think, to create a model of hospital to home transitions. And that kind of uses all of the precise activities involved in the transition and really breaks down the process into these different functions and inputs and outputs. And so it was a really kind of quantitative kind of approach to things as well. And so I think that having those kind of collaborations where, at face value, you might think, oh, I don't know how those things are going to mesh necessarily. Sometimes you really need a huge departure from how you are normally thinking about things. And I think that can really shift your thinking and help with creativity and generate some really interesting findings. So yeah, bringing together researchers with various areas of expertise was really valuable. And there was a lot to learn from one another as well. Yeah. Okay, so I think that's all for me. I think 3:34, I think we're doing okay. So
Wait, that was a fantastic synthesis of the amazing work that you and your team with SOAR have been undertaking. And you've identified some really critical gaps and certainly shared some valuable tips for everyone on the line, no matter our background. We have a real variety of people attending today, people from healthcare, academia, students from various disciplines at different stages. So thank you again for that.